I'm going to turn this over to Dr. Smelter, who's going to share a couple questions that came forward from the audience already from on note cards. And then, Joel, if you'd just be available to make sure we can grab whoever has questions in the audience as we move through. So I'm going to let you.
Okay. Hello again. So the first question that we got from the note cards, there are programs in place to integrate MDs, family practice and surgeons. Are there any plans to integrate family nurse practitioners, PAs, or CRNAs in the future into medical missions?
So I have one of these, so I can probably take that, and the answer is yes. I think that as depending upon where you look in the world, the vast majority of primary care that's provided in, especially at the health outpost level, is provided by what would be senior nursing staff. And so nurse practitioners is an easier role sometimes than PA, although there is a big place for PAs to join as clinical officers oftentimes in most of the African countries. And there is ways to integrate certainly nurses into nursing education. Nursing education looks really wide as far as there's a whole. It can be at LPN level, at the baccalaureate level, up to a master's level in some countries. So it really depends on the countries. But certainly at the education level in nursing, that's a big need. In PAs, it varies significantly from the country, depending upon whether a PA can be licensed or not.
Great. I think Bruce has an answer, and Arnie also, right?
So in terms of any personnel from the West going to anywhere else in the world, we're subject to immigration of a country, and I think it's important to just remember that in some countries there's a lot of scrutiny around what roles are still needed in their country that can't be supplied by people who are already in the country. We do that ourselves, given the immigration debate we're having in this country. So immigration by merit, if you will. So the last time I went to Kenya, I've been going to Kenya for over 25 years, but the last immigration forms that were filled for me, the university had to declare that the role I was going to play as a family medicine program director had no other person who could take that position. That wasn't quite true, because there were some graduates of Kenyan graduates of family medicine who potentially could, and I obviously trained my successor, a Kenyan, to follow me. But with my degree in health professions education, there is no other person in Kenya that's a family physician and has a health professions education degree. So in that way, I had credentials that allowed an immigration official to say, yes, you can come. So when you come as a nurse, are there nurses in the country where you're at? Well, yeah, there's plenty of them. Some immigrations are going to say, so what, come and join the party. But others are going to say, well, in what special role is your nursing expertise important? And that's where having your additional degree or your master's degree or your education degree or your midwifery education certificate, becomes the role that you're going to play. And as we've been discussing, so many of things in medical missions across the world, and not just in the church sector, are built on the education, the theme of the session we were in. Education is where things are moving, and so you need experience, you need experience teaching, get that as you go along, and get additional training so that you can be a person who is has something additional to offer in a country.
Yeah, I agree, but I think as far as the long term, but as far as short term, I think there's just wonderful opportunities. One of the first things I always did as a chief of service going into a new duty station was to hire as many nurse practitioners as possible, because my goal was to keep the kids out of the hospital. Now, us docs were really great once they come in, but to keep those kids out of the hospital, to keep the abuse from happening, to keep the admissions for dehydration and all the other conditions that so often end up in the hospital. To keep those out of the hospitals, nurse practitioners are much better at this than docs. And on short-term missions, there's no one I want more on my team than the nurse practitioner, because they know how to teach. So.
One more important thing, licensure, short-term especially. Many short-term teams that go haven't even thought of the fact that they need to have a license to practice when they're going to do such good things. In most countries, in fact, all countries, there's a licensure pathway that is important to be at least observant of. Yes, in many places, they kind of wink, nod, and look the other way. But if you haven't researched to know that that's the case, and you're illegally practicing medicine in a country, what is the ethics of that? Well, it's a pretty dark stain. So it's a very important thing to at least check out before planning your next trip, if you haven't done it already.
I agree. Very important.
Yeah, thanks. Did we have any questions from, we also have a roving mic with Joel, if there are audience questions. None yet? Okay, one in the back.
So my question is for Dr. Thilander. Earlier today, you had talked a little bit about the difference between Western cultures and Francophone cultures in terms of training. So could you tell us a little bit more about that, and also some resources that might help us with that?
Yeah, sure, I'd be happy to do that. So in short, we could talk for days about that, but to make it short, teachers know everything. Whatever they say goes. You don't ask questions as a student, and if you fail, it's your fault. Western thought is, and often, we don't know everything as teachers. If my students fail, it's my fault because I didn't teach them well. That is not the general thought in most of Francophone Africa. There, of course, are exceptions everywhere, right? But that's generally how it goes. As learners, you don't ask questions if you're in a Francophone culture. You write down everything the teacher says. You probably didn't have a textbook unless maybe, well, even now there's no textbooks. You might find something on the internet, but you didn't have that before. So whatever the teacher said is exactly what it was, and that's what you needed to learn, and you just read it. You didn't understand it. You just memorized it. That's not what we expect, obviously, now. We think, why would I memorize this? I can find that on the internet. I can find that table of things somewhere else. I don't need to memorize the table. I can always go find it. I need to understand it. So teaching understanding versus just basic knowledge and facts. Way oversimplification, way over, but you only give me a few minutes unless you want to talk for an hour. Resources to learn that. Pretty much anything that's going to talk about the different cultures. A lot of my resource was observation, being there and talking with my residents who were Francophone and hearing them say different things and learning, making a lot of mistakes, still do. So that was a lot of my resource for me personally, but there are some things online that will just basic, what is a shame-based versus a reward-based culture, and what's that? Guilt. In a guilt-based culture, and not everyone's attribution, I don't agree with everyone's attributions on that, like what they think is shame-based, it's actually maybe more guilt-based. In other ways, or very fatalism, how does that play in? So there are a lot of resources. I can't give you a specific thing. If you're looking at cross-cultural partnerships, there's a lady named Mary Leiter-Leitner who wrote a nice book about cross-cultural partnerships. Nice if you want to understand them, not nice about some of the revelations, because it really exposes some of our Western mindset that doesn't work very well.
Stories are always the way Africans explain things. I'll give you one short one. My wife was teaching, she's a nurse educator, was teaching the nursing assistant course, just the folks that do the manual labor on the wards. And being a good educator was asking for questions, and there were no questions. But she could see from the look on the faces that things weren't getting through. Some of it's language, her American accent isn't as well understood, etc. Towards the end of the several-week course, somebody finally came to her and said, afterwards, after the class was gone, and said, Mrs. Dahlman, we really don't want to ask a question. Well, why not? Well, because that would mean that you didn't teach us well, all right? We're going to save you from the shame of thinking that you didn't get the point across by not asking a question. So you can understand that, I mean, in the paradigm we have of education, where it's a collaborative process to learning, we all have something to contribute. The student, even though they're not the expert, might have some insight that we could learn from. All of that is off the table. And had interns tell me I would like to start the internship year by, telling that Kajabi is a learning community that we all want to learn together. That statement still can go. But if the next statement is, I have something to learn from you sometime this year, I might as well have just shot my foot and said I'm not a good teacher, right there. Because, what? You're not the expert that I expect to learn from, right? So those cultural expectations around learning are quite broadly, it's a big chasm there. And of course, the important part for the long term is, if I'm going to try to help teach a team how to be a good response in an emergency situation, what does that take? It takes everybody doing their part. And if we don't have a team, we don't have an emergency response. So if you can imagine then, what are we going to do to help make the change from doctor is the one who says everything, knows everything, and I just do some task? It's not going to cut it if it's a true, a broad emergency. So it only happens with time and the trust that comes from a relationship, that they can actually see that you're not going to bite them for asking a question. All right? And so if there's anything to learn from cross-cultural living, it's relationship, relationship, relationship. And how does that happen? Language, language, language. You got to know their language. You got to understand as much as you can, and you'll always be learning throughout the rest of your life.
Yeah, I have all kinds of things going inside of me right now, because when it comes to community health and community engagement, the whole process is about helping them think through problems and build consensus as a community, which requires both inquiry and dialogue. And so I remember going into Myanmar one time, and first thing we did was put the chairs in a circle and take them out of rows, and we threw the whole place into chaos just by that simple thing. And then I sat down and we began, we posed a problem, and then I asked questions. And they didn't answer questions. And so I would say, that was a question. And they would write down, that was a question. And then I would say, you're supposed to answer questions. And they would write down, we're supposed to answer questions. It took 3 days. But there are a lot of reasons why they don't. They're afraid to venture an opinion because of the shame that it might bring. In Myanmar, it's because people who have opinions get hurt. And there are a lot of reasons why they don't. But in community health, where you need community engagement and consensus, you have to break through some of those cultural barriers. Even for Americans, what we do is difficult. Yes.
I'm just going to add a plug that we added a new course or workshop to our training programs at Christian Health Service Corps last year that's co-sponsored by CAP and PACS and CMDA, and his image was part of it last year, Project MedSend, African Mission Healthcare, which is on teaching healthcare in a global setting. So that's coming up in September. Again, on our little postcard or at our booth, you can find information. Let me read one here, and then we'll go to an audience one. So, first I want to thank very interesting and thought-provoking sessions. So it has taken the medical mission so long to refocus the attention to partnering with communities, listening to the needs of the people, leaving in place a sustainable structure. How do we get donor agencies and organizations to do the same? Who wants to take that one?
Yeah.
When you figure that out, let me know, because I'd like to raise funds for my organization.
So I think you can tell stories to your donor organization. Stories like, we like to make numbers, and they want to see numbers. So there's a story, and I don't know where this took place, but it was that every mission organization serving in that area added up the number of conversions they had that year. and it was greater than the population. That was you. So, great. So you can speak to that. I don't even know where it was, but I know the story. See, you don't have to have your own stories. And you notice I'm keeping the microphone. You can tell someone else's stories.
It happened in the Philippines. I was the international director at Medical Ambassadors. We were receiving the reports back from the field, these reports back from the field about how many people came to Christ and so forth. And it was actually over a period of years, and I looked at the reports and figured that in several villages, they were reporting more people had come to Christ than there were people in the village. And so, yeah, that was, yeah.
Thank you. That was good. Now I know who to give credit to. I've just been telling it vaguely. So how you take that to orient the donor base to understand is help them. What is their goal? Why are they giving? Are they giving so you can, I'm a surgeon, to do 200 surgeries? Or are they giving to have a long-term impact? And their answer will always be, we want to have a long-term impact. Okay, so stop asking me how many surgeries we did. Ask a different question. And they're going to say, well, we don't know what question to ask. So you have to have a preparation of what question am I going to ask that will help them give data or information, because the donors want data. They do. They just want data, and you can't blame them, because how are they going to promote things if they don't know what data they have? And so you have to provide them data that you can do that makes sense for what you're trying to accomplish, not just the data they're going to ask for.
Can I speak to that just quickly? I have the lapel, but I think that it comes down to education, and one of the reasons we do what we do in one-day workshops like this is we want to grow our understanding as a community, not just in the medical mission community, but in your donor communities. So I hope that when you process information like this, that this is something that you can use to educate your partners. Because they're as much a part of the work that you're engaging in as you doing the work on the field. And it doesn't happen without financial partnership, but helping them come along and grow with us in our understanding of missions is really important. And sometimes you have to be kind of strategic in that, and kind of leading them in their understanding of how missions really works. One of the resources that we use a lot that I give to partner churches is a Steve Saint video series called Missions Dilemma. It's a phenomenal series because it talks about how do we do missions with people, and how do we really do it in a way that truly supports human dignity. And I think that one educational piece takes, it really shifts mindset. So look for tools like that you can leave in the hands of your partners and your church partners and your donors. And I think you'll find that they come on that journey of learning with you.
Another answer to the idea of how do you engage donors to ask the right questions and ask the right numbers is you got to think about what donors are. They represent some either group or a goal that wants to be accomplished. So there's a continuum on a couple of fronts. One is an easy one, length of term. Is it a quarterly or a yearly goal that they have to meet? The numbers get to be really important, because how can you justify the next year's budget if you haven't shown any results? And so the measurement's very important. If you're thinking longer term about development of a primary care healthcare system, how do you measure that? Very hard to measure. But I'm telling you that all of the project-oriented, results-oriented organizations are starting to realize HIV after 20 years, the numbers don't matter as much if you don't have the system in place to take and continue it on. So that continuum is the time horizon. Another continuum is how broad is the vision? So if you're a siloed project, I'm working on malaria, I'm working on HIV, I'm working on helminths, I'm working on something. Well, then you got to have numbers, because you got to know that there's less worms in the world, today than there was yesterday. If you're talking about a primary health care system strengthening so that the the healthcare workers are staying in place and actually doing a more effective job. Harder and harder and harder to measure, but I think all of us in our primary care world would say that's a much more important long-term goal if you're going to see the health of the population rise. So those are some horizons that all get to be a part of it. And I guess I would end by asking, are we immune from it in the mission world? What is the metric that my mission, AIM, uses to talk about our success in things? Yeah, it might be souls saved, okay? But another metric is, how many long-term missionaries did we send out this year? Number, okay? We sent out more this year than we did last year. I would submit to you that's the wrong metric. Why? Because I can't tell you how many people came to my door as medical director at Kajabi announcing that they were long-term, life-term medical missionaries. Aren't you glad to have me? And I can tell you on a hand the number that stayed more than the first term. The metric is faulty. If we can get people there and they burn out within a term, how does that help? How does that help? Well, it's 4 more years instead of 2 more years, I guess. But if they came expecting in God's provision over years of preparation, 10 years for most of us docs, from the time we feel called to the time we're ready to prepare, have raised our support, our churches are behind us, and you're gone in 3 years? And probably it's mostly because of the missionary issues that come up. That's probably one of the number one reasons missionaries leave, is because of other missionaries. Well, we got a few things we should be working on that we're not working on because the metric is wrong. And so we have some of the same issues even in our own circles that we have to be pretty honest about.
Well, like missionaries get hot the money.
Yeah.
I think, John, did you have something to add, John Crouch?
One comment is to say, one of the things that's really nice in terms of looking at how you report things to your donors, I like what PACS does with their reporting of the people they've graduated and tells their personal history and what they have done in terms of their education and where they're gone now, and also their spiritual testimony. I find that making me want to give to PACS, and so that's kind of a very good, I think a very good metric to take a look at. I want to make one other quick comment, which is kind of on the previous subject a little bit, and that was we're talking about Francophone and kind of Western. One of the things that you have to think about a little bit that we have is there's also another culture in the world. That's the Asian culture, and a whole variety of those Asian cultures, and that's a whole thing too, because that really is kind of like the professor of medicine speaks ex cathedra, and everybody listens. And so there's one of the things I would say about that is, as Dan Fountain used to say, you have to really create a paradigm shift. If you're going to do education in these different places and different cultures, you have to recognize that it's going to take time, because there has to be a paradigm shift, and a paradigm shift is not something that takes place 1, 2, 3, 4 and it's done.
Thanks. Any other questions from the audience at this point? We have one up front. Did you? Okay.
Thank you very much. So I have a concern here. I'm from Liberia in West Africa, and I want to know what are the limits on donors' funding. For instance, during the civil crisis in Liberia, I was in one of the villages when they had this group called Médecins Sans Frontières. I think you will be familiar with that. And in my village, someone was actually wounded by a bullet. And when the guys came on front with their car, they said they couldn't help that situation because it was not within their budget or their donors' funding range. However, there were other people before who were assisted in similar situation. So my thing is, I've been very doubtful as to saying maybe they have selective things that they do and they can do other things. It brings back to my mind, do they do assessment of the places they want to launch these projects or these donor fundings to know what the people actually want? Take, for instance, someone said today, why would you build a well in the community, and the people leave the well and go to the stream to go draw water. It's because probably they didn't even know what they wanted, and when you did a well for them or a hand pump for them. So what do these donor communities do to make sure to help these people if that's what they are going to offer? Is it to help the people, or they have their own objective that they want to achieve? Thank you.
Terry, you want to speak to that?
Well, yeah, I'm not sure I understood everything that you said, but your question in short was, how is it that you can get to the field and have funding for this and not that? Have we not done an adequate assessment before we introduced the program about how much it was going to cost?
Whether your intention in the field is only about what you want to achieve, but it's not about the people in the field. Because if it is about the people, an assessment would have been done to assess their need to find out what is it that they want versus what you want. For instance, if you're going to African culture, you want to understand the way of life of the people.
Oh, yeah, okay.
So if you don't understand that, you have lots of problem. Why do you think a student will not ask a teacher in the class? Because we're not just used to talking to our superior just like that. If we have to do that, it has to be channeled in a different way. So how did we come to say we want to go here when we don't know how and what these people concerns actually are or is?
Right, yeah. So part of what we need to learn is to pose problems and allow them to create the solutions. And I was thinking about a story in my own experience where when I first got into integrated or holistic ministry, I set up a church planting institute. And we called it HATCH, a holistic approach to church planting. And the only thing I knew to do was to go to the city and get clothes and doctors and medicine and go deliver it in the village. And in the course of doing that, problems emerged. People began to complain because this person got a scholarship and that person didn't. And it got so bad that people in the church were blaming the pastor for keeping resources they thought were being delivered to them from the outside. And I realized that we had created dependency by our actions because what we had done is built the expectation they're going to hand the problem to us, and then we're going to do the thinking and we're going to fund the solutions. And so for me, imagine that I am a villager and I am sitting here holding this problem. And what's your name? Franca, come on up here, okay? And you come to me. You have shoes that cover your feet, nice clothes, a suitcase. You came in a four-wheel drive. You flew to my country on an airplane. And I've been thinking for a long time, I can't solve this problem, but you've got all those resources. So I'm going to just do that. Now, as soon as she takes the problem from me, what happens? Now it's her problem, not mine. Who's going to do the thinking? She's going to do the thinking. Who's going to get blamed if it doesn't work? She's going to get blamed, right? The problem is you can't let that exchange take place. When you do that, you have begun the process of creating dependencies. And the end result is going to be questions. Why are they getting this and they're not? And why is this priority and not that priority? And so two things. We don't want that exchange to happen. And the second thing is we have to use processes that allow the community to communicate and choose their own priorities. I don't know if that answered the question. But
I'm going to read one from the note cards that comes up often. There are organizations that insist on delivering medications in Ziploc bags because that is the way they have always done it. How do you change that mindset? Greg?
Well, I don't know. I've been working on it for about 2 decades now, and I'm not sure I've made too much headway. I think that realizing the research that's out there, the evidence base, is there for a reason to support what we do here. And that is transferable. I struggle with when I go into hospitals and they're doing it, because they are. And so how do we even move the hospital infrastructure along to say, hey, guys, we need to, and then when we come alongside that and support poor patient safety practice, then we're kind of as much to blame. So we need to be the examples. We need to lead by example. If you're going to go and do healthcare in a community, it's so cheap to go and buy child-resistant containers for medications that are going to be dispensed. Just like a pharmacy would do here, if you're going to set up a pharmacy in another country, it doesn't matter where, you're still going to be responsible to provide that packaging to assure some level of safety for children. It's still a battle I'm fighting, and I've been carrying that to a lot of conferences over the years, and I think we're gradually making progress. If people can understand the need and understand that, you know, we do lose 125 kids a day due to poisoning, according to World Health Organization, and the vast majority of those are pharmaceutical. And I shudder to think how many of them are coming out of Ziploc bags from well-intentioned Christian medical teams. So it's worth a thought. It's worth investigating how much it would cost to buy a duffel bag full of pill bottles because they're cheap. So.
Yeah, you know, I learned more about the harm I was doing in short-term missions from my long-term experience down in Baja for about 15 years. That area had actually the highest mortality rate in all of Central America. Is mainly because they were developing that area into cooperative farms, and we get most of our strawberries and tomatoes and so on in our country from there, and that's why they're so cheap. But they'd bring in these Indian migrant workers from southern Oaxaca, who's essentially unreached people groups. You send a missionary out there and they don't come back, you know. So a population that was very, very primitive. And I don't know why I didn't do this sooner, but one of the experiences that made me stop going on any kind of drug-based mission at all was when we finally had the idea. Well, we noticed for a number of years that after a short-term, this is only 200 miles south of the border, so we get short-term teams from California and Arizona quite frequently. And we started noticing that, you know, the poisonings went up in kids. Actually, the picture that we have on harm from drugs and short-term missions, or harm from drugs on the slides, that was a girl with poisoning, and Ziploc bags. And what we did was, you know, and we didn't have the resources to keep data or anything, but all we did was we went into their hovels, and we asked them 2 questions. What medicines do you have, and how do you use them? And oh my goodness, you know, they'd pull out these baggies, you know, full of, and they'd take a red one on one day and another one on another day, sometimes 3 or 4 different types of hypertensives, you know. And we had, in addition to the high infant mortality or child mortality rate in that community, we had a very high rate of unexplained mortality in the relatively healthy 40 to 50-year-olds. And we couldn't prove it. You know, we can't prove it that it's higher than our drug-based mortality in the States. But, you know, we don't have the resources to do liver biopsies or kidney biopsies or autopsies. But, you know, those surveys did show that every time a short-term mission went through, those incidences went up. And there's two deadly beliefs that are identified. And one is that these medicines are important for us. And the second deadly belief is these medicines don't have adverse effects. And their reasoning is this, that why would that wonderful Christian group come all this way just to give us to them if they weren't that important, or if they had adverse effects? So those are the two deadly beliefs. And I don't know the answer to that either, except for me, it was, that opened my eyes. So.
Arnie, one question regarding that. I know I've heard you talk a lot about NSAIDs and GI-related bleeding and problems associated specifically with NSAIDs, which we seem to give out like candy in the developing world. Can you speak to that in just some of the research that you found?
Well, yeah, and this is everything I present is from the very best journals. This is from the New England Journal of Medicine. And I think the title was of the article from the New England Journal of Medicine was how many deaths does it take to get a black box warning? And what they were reporting on just the number of GI deaths alone from arthritis patients alone in the U.S. alone. And how many do you think that was? Well, it was over 16,000 deaths per year. That's more deaths than we had from AIDS, from many other conditions. So, arthritis was a previously non-lethal disease in our country. We have made arthritis, osteoarthritis, a lethal disease. And as we showed from the slides, that's not even, well, when we were prescribing NSAIDs, they were still on, from an evidence-based standpoint, still the drug or the treatment of choice. Now they aren't even the treatment of choice. So, and that's only the GI deaths. The number of cardiovascular deaths just from rofecoxib alone was over 55,000. So these are tens of thousands of deaths every year in our country just from NSAIDs that we do pass out like candy, and we did it as well in baggies as well. So.
We probably have time for one more question. Yes, Joel. Thanks.
Thank you so much. This is just, I think it's a basic question. For people like me with little experience with medical mission, but highly, I feel called into that, but I don't know how to go about it. Can somebody just give us a little bit of an idea of how to go about, getting started, what resources are out there, so we just don't feel lost?
Come to the M3 conference and go to the exhibit booths. Good job that you're here. What else?
Yeah.
If there's anything that anybody on this stage has ever learned in working in medical missions, it's relationships matter. I don't know you yet, but I'd love to meet you. The Lord's given each one of these people experiences that they could talk for several hours of the ways God has showed them the way and how the next step wasn't known, but they put their foot up and the Lord guided where that step was going to go. We all have those stories. It's a life of letting go and letting God, to use that very cliched phrase. And those, the encouragement to do that is just by chatting with some of the people in the booths. You can go out to the booths there and you can talk at this level, or if you want to sit down on a chair, behind and chat for an hour, we love to do that. That's how it starts. And exploring with you, what has God already prepared you for? What has the Lord given to you in your spirit as something that He's impressed that is important? And what are the skills that you can bring to that? Past experiences that might have been a hindrance in the past, but now can be utilized as an opportunity. Yeah, relationship. Let's talk.
That's good. I'd like to speak to that too, just in the sense that there are a number of organizations that do short-term medical missions really well. and they plug in short-term teams. If your passion is to go and do community primary care as a team, there are some great programs out there on the field that really, I don't want to say cater to groups like that, but really work well with teams like that and have figured out really good strategic ways to fit teams into what they do. I send teams to, or we connect. We don't send short-term stuff, but we connect teams to places like the Jungle Hospital is one that I could think of in Honduras that they work within all of the rural public health clinics. They have a small hospital and clinic, but they also work within the public health system in the region, and they plug teams in, and they have charts on all the peoples, and they do such a great job of really facilitating mission teams in a way that is really productive. So most of the people up here can connect you, and I think that what Bruce is saying about relationship is really good, because we have ways we can connect. I would say if you're a physician, really look at Samaritan's Purse World Medical Mission. They're really good about doing all the logistics for putting you in a mission hospital context where you can be effective, and they do a really good job of that. They'll arrange all your local medical license, temporary licensure. They'll get your travel done. They'll do, and you'll be in a place serving alongside, or maybe trying to take some of the load off the long-term medical missionaries serving at those places. So that's a real great way to plug in. And there's also opportunities for nurses and nurse practitioners to kind of do the same thing. Any anesthesia providers or CRNAs, you would never be without work. We could use you in pretty much every place on the planet. But communicate, use this time that you have at the conference to network, as Laura said, and really connect, because there's some great places where you can plug in and be effective in ministry.
And if you're interested in community health, there's a number of people that have already approached and want to have CHE training here. There's CHE training at the Christian Health Service Corps every year. And spending a week in training with others will also be something, developing relationships and maybe a starting point.
Yeah. One of our families is going to be doing a CHE TOT1 every summer in Uganda now that lives there full time, and they'll be hosting and housing and being able to do kind of an intercultural CHE initiative where both Ugandans and North Americans can learn together. And I think that's so valuable in fact, Shem is Ugandan, so it's really kind of a nice mix to look at. What does it look like to learn how to be a community facilitator in that context? And I think that may be a really good opportunity for folks.
So I want to thank all of the panelists and everyone for presenting throughout the day, and all of you for coming. And actually, I think all of our organizations have booths here, so we will be here throughout today and tomorrow for all of the questions that we missed. We apologize, we don't have enough time to answer all the questions, but come and talk to us. Yep. Did you want to close in prayer?
Yeah, let's do that. Father, we just thank you so much for your faithfulness. We thank you for the opportunities you give us to serve. We thank you for everyone you brought here today, Lord. We know you're working and stirring their heart to serve you in different ways. Give them the faith to take that next step. We know that sometimes you don't give us the light on the whole path, but you're faithful to shine the light at our feet so that we can see the next step. Lord, allow this to be a time that people are able to find their next step, to step out and serve you. Thank you for this day. In Jesus' precious name, amen.